Good morning. My name is Ben Matone, and I'm Senior Director of Investor Relations at Inovio. We're excited to have you join us for the first ever Inovio webinar entitled DNA Medicines from COVID-19 to Cancer. Before we begin, I'd like to remind everyone that we will be making certain forward-looking statements regarding future events that relate to our business plans to develop Inovio's integrated platform of DNA medicines. These include clinical and regulatory developments and timing of clinical data readouts and strategic matters. All of these statements are based on the beliefs and expectations of management as of today. These statements involve certain assumptions, risks, and uncertainties, and could cause actual results to differ materially. We assume no obligation to revise or update forward-looking statements, whether as a result of new information, future events, or otherwise. Thank you again for being with us today. And with that, I would like to turn the presentation over to Dr. Joseph Kim, President and CEO of Inovio.
Good morning, and thanks everyone for joining today. My name is Joseph Kim. I'm the President and CEO of Inovio, and I am delighted to be hosting our first DNA Medicines virtual meeting from COVID-19 to cancer. Our goal is to provide you with an overview of our unique DNA Medicines platform and our most recent data achievements, including our preclinical and clinical work on our COVID-19 DNA vaccine, INO-4800, and also the data we just recently presented at ASCO on our DNA immunotherapy, INO-5401, for the devastating brain cancer glioblastoma, or GBM. Today, we will be hearing from our Inovio team, including Dr. Kate Broderick, our Senior VP of R&D, and team leader for our COVID-19 DNA vaccine development program, and Dr. Jeffrey Skolnick, who is our VP of Clinical Development for Oncology and Inovio. Drs. Broderick, Skolnick, and I will also have the distinct privilege and pleasure of speaking to renowned experts, including Dr. David Weiner, who is often referred to as the father of DNA medicines, Dr. Stanley Plotkin, who is considered among the world's leading vaccine experts, and the scientists who developed many of the vaccines that have protected humanity from such viruses such as rubella and rabies, and Dr. David Reardon, who is a leading neuro-oncologist focused on brain cancer research at the Dana-Farber Cancer Center. My team and I are coming to you live today, now, and for our Q&A at the end. Our conversations with Dr. David Weiner, Plotkin, and Reardon were recorded previously. Later this year, Inovio will host a similar webinar focused on our lead asset, VGX-3100, currently in phase 3 trials to treat cervical precancer related to the human papillomavirus, or HPV. We'll have phase 3 data to share with you at that time. So let's get started, and please be sure to type in your questions as we go along, and we will do our best to answer everyone at the end of our presentation. Inovio is powering a new decade of DNA medicines. We have done this by developing a powerful platform that involves precisely designed plasmids delivered with smart proprietary devices. We have gathered strong safety data in over 2,000 patients, along with immune responses in these volunteers and patients in clinical trials, including our lead product that is already in a phase 3 randomized double-blinded pivotal trials for VGX-3100. We have already presented great data from our phase 2 trials involving our glioblastoma treatment, INO-5401. We've also demonstrated previously strong meeting of primary and secondary efficacy endpoints from our phase 2b trial for VGX-3100. Of course, our fast response vaccine platform has demonstrated off-the-shelf speed and efficiency, as well as immune responses from our technology platform. Inovio has been executing on its vision to build and lead a DNA medicines company. Our vision has been executing our precisely designed plasmids that target specific antigens, whether they're from viral sources or from cancer. We use our smart proprietary device, Selectra, to safely deliver directly into the cell of a person our DNA plasmids that can generate very strong and robust immune responses. And of course, we have validated this work with extensive partnerships and collaborations and peer-reviewed publications. We have been executing in the near term by advancing our products against HPV, cancer, and infectious diseases. And of course, we are here to meet the urgent medical needs of the patients worldwide. In the long term, we feel that we have the extensive and strong financial position in terms of cash, also the human resources position, and our network of partners and collaborators globally to create and deliver safe and effective DNA vaccines. How is our proprietary technology platform built, and how are we executing this? Well, as I mentioned before, Inovio has been executing the precisely designed, optimized plasmids by targeting the gene sequences for a specific antigen from COVID-19 to GBM target antigens. We plug that into our backbone plasmid, and we deliver efficiently using our proprietary smart Selectra devices. Shown here, both our immunotherapy device in Selectra 5PSP on the left, and our new commercial vaccine device called Selectra 3PSP. When delivered, these plasmids then can generate powerful and safe immune responses, and we have demonstrated this in over 2,000 patients and volunteers thus far. Now, Inovio's technology has demonstrated significant advantages over time. We have demonstrated clinical efficacy in our randomized double-blinded phase 2b efficacy trials. We've also demonstrated an ongoing safety across over 2,000 patients and volunteers in over 6,000 separate administrations with very favorable safety profile. Compared to other platforms out there, we think this is one of the strong advantages of Inovio's product platform. Because also that there is no anti-plasmid immune responses that can thwart our efforts to generate additional boosting effects, we can certainly dose multiple times using the same vaccines and immunotherapies. In fact, our cancer trials, including GBM and prostate, these patients have been receiving our immunotherapy up to a dozen times or even more across their treatment with a favorable safety and tolerable profile. And lastly, one of our greatest advantages is the stability of DNA vaccines products, where we have demonstrated a strong and stable stability of the product long-term, up to 5 years in refrigeration, normal 2 to 8 degrees Celsius, without requiring the deep freeze stability that many of the other platforms require, up to -80 deep freeze conditions. We've also incredibly demonstrated over a year is of storage at room temperature of our vaccine candidates, which is amazing. And we're able to scale up using the standard biomanufacturing processes, the manufacturing of the plasmids and the devices, of course. We are increasing the manufacturing scale of our devices and arrays through automation and additional contract manufacturing lines. Next, I'd like to go through a summary of our very extensive DNA medicines pipeline. In this slide, we show our overall immunotherapy clinical pipeline, headlined by VGX-3100, which is a treatment for precancerous conditions caused by HPV infections. The lead indication is for treating cervical precancer called dysplasia or HSO. And we're looking forward to providing top-line efficacy data from our first phase 3 trial, REVEAL-1, in the fourth quarter of this year. We have already presented some very exciting interim phase 2 data for our vulvar and anal dysplasia studies this year. We would also report the complete set of those phase 2 data later this year. Next is our recurrent respiratory papillomatosis, or RRP treatment, INO-3107. RRP is a rare orphan disease, and we are very excited to open this trial in phase 1/2 setting to demonstrate the safety and efficacy of this treatment in preventing or extending the needs for surgery of this tumor that grows out of control from HPV-6 or 11 infection. So we're very excited to start this trial mid-year this year. MEDI0457 is a product that we licensed out to AstraZeneca, and they're conducting multiple phase 2 trials of 457 plus their PD-L1 checkpoint inhibitor in multiple HPV-caused cancer indications. And as I mentioned earlier, we would also be talking about INO-5401 with this recent data that we have presented at this year's ASCO with Jeffrey Skolnick and David Reardon. But our GBM therapy, INO-5401, has demonstrated better than standard of care in PFS6 and also overall survival at 12 months. Stay tuned for this information. And we have also phase 2 studies, efficacy setting trials going in our collaborations with PICE and Cancer Research Institute in prostate cancer of combining our INO-5151 plus multiple immune modulators in castration-resistant prostate cancer patients. Moving over to our DNA vaccines pipeline targeting infectious diseases, really is headlined by our work against COVID-19, which is INO-4800. You would hear a lot about our advancements and progress in this vaccine in very short periods of time. Inovio has built a global coalition of collaborators, partners, manufacturers, and funders to advance INO-4800. And we're looking forward to reporting on phase 1 data later this month, but also starting potentially our phase 2/3 efficacy trial in July, August timeframe. And we're very excited about the progress of this program. We also have other vaccine work that's advancing to the next stages, including our vaccine for MERS, which we plan to enter into phase 2 trials later this year with the full funding from CEPI, as well as our Lassa fever vaccine, INO-4500, which we plan to enter into phase 1B study in West Africa with our eye towards starting the phase 2 trials in the region later following the phase 1b study. Lastly, I'd like to introduce how even in this day and age, especially during the pandemic situation where the speed and the sharing of the information is so critical, Inovio is very proud to say that we have been publishing our research and development results in peer-reviewed journals, including over 150 preclinical and clinical trial data in peer-reviewed journals and papers such as The Lancet, New England Journal of Medicine, JID, and Nature. Most recently, we have published the immune responses data from our preclinical models for our COVID-19 vaccine, INO 4800, and Inovio believes in sharing and letting the information to be shared with the public through our peer review system through these world-class journals and publications. All right, now it's my pleasure to introduce Dr. David Weiner, considered to be the father of DNA vaccines, one of the key pioneer in the field of DNA medicine. David, it's great to be with you here.
Joseph, it's wonderful to be here with you.
So I have some questions about DNA vaccines and DNA medicine. So how did this start?
Well, that's a really interesting question. When we started this several decades ago, really there were two technologies for making vaccines, live approaches or dead approaches, or non-live. And live approaches really were our favorites because by growing inside our bodies, the immune system learns to fight off the infection, and also because the virus actually replicates and produces proteins inside our bodies, we can not only make antibodies to the soluble proteins that are produced, but also our killer T cell compartment, the Navy SEALs of the immune system, are engendered, which can then expand and contribute to viral clearance and better protection and control. And so that was the hallmark of live infection. However, live infection can take very long to make and be safe and has lots of other developmental issues. Non-lives really have a whole safety advantage because they're non-live, but they lack many of the immune functions of the live approach. And so we were thinking if we could deliver a non-live, non-replicating, completely controlled piece of DNA and code the instructions, the cells of the body would make the proteins. They would, again, stimulate an immune response antibodies by being shed from the cells. And because it's also made within the cells, it would have the hallmark of induction of killer T cells. And because they're non-live and can't spread, they would actually have the safety, therefore, of the non-live. And so you'd wind up with the best of all worlds. And also, DNA is really simple to manufacture.
So what do you think is the most unique character of DNA vaccines?
Well, that's another really important focus that we have been on and along this journey collaborating with Inovio. The sequences themselves are not derived from any organism. They are designed by computer and there are algorithms that Inovio has now developed that enhance this design and make it very rapid and very reproducible. It's also the vectors themselves are reduced to practice. The manufacturing system is very consistent, and the delivery has been simplified, and the formulations have been improved. And so this is a local delivery for a local expression only in the skin or in the local arm, no production other parts of the body that can produce proteins that can be seen by the immune system and stimulate a strong immune response as if they're an infection, and also generate very consistent levels of CTLs in this very reproducible, consistent delivery platform.
So David, you and I have been working on DNA vaccines for over 25 years. So a lot of people ask me, what makes mRNA different from DNA and vice versa? And how would you compare and contrast two different technologies?
Well, mRNA and DNA are both genetic material, but they have very different purposes. DNA is kind of the library of information. It's very stable. It can be extracted from extinct animal systems from thousands and thousands of years ago. And that is just a credit to how stable it is. And one piece of DNA can make many, many messenger RNAs when it gets into a cell.
So I believe the main difference between DNA and mRNA vaccines in people are DNA's ability to generate, as you mentioned, CD8 positive killer T cell responses, and mRNAs have not. Can you explain why that might be so and what people have been seeing in the clinic?
Well, right now we have very little DNA, information about RNA in the clinic. There's only been a few studies reported, and of course, we're learning more and more. But what has been reported is they can, with multiple injections, drive T cell responses, but it seems like they're biased towards CD4. The DNA seems, which we have a lot more data for, a lot more published data. There's, especially in the clinic, is driving both antibodies and CTLs.
So, what concerns you most if you look at the DNA vaccines, and also looking similarly at mRNA vaccines? Well, from a scientist and from a vaccine developer's perspective, what would be your greatest concern, and what could be the greatest positive from those two vaccines?
So I think we're in a unique time that nucleic acid approaches such as DNA and RNA are being considered and moved to the forefront, and we're on display through the CEPI funding for COVID. They were the first two vaccines that were moved forward in the United States, for example, through CEPI funding, and they were both part of the first three groups that were funded by CEPI. So that's quite an interesting thing, and that speaks to the advantages in concept these have for moving into the clinic rapidly, delivering something people believe in a simple, rapid fashion, and also possibly providing benefit. DNA, we have had several indications in the clinic of the first appearances of efficacy. The treatment of HPV-induced cervical neoplasia, a double-blind placebo-controlled trial that was published in Lancet a few years ago, showed efficacy. Early effects in GBM have now been reported out of Harvard that this was having some effect, although we haven't hit a true efficacy endpoint yet. And immune responses in infectious diseases that for emerging infectious diseases that look very, very similar to what we might need and might be associated with protection, but we haven't. We have more work to do. RNA is still earlier. We've seen some reports. We've seen a flu report from Moderna, and particularly, and then we've seen some other public reports, but those papers are not out yet. There have been some reports from other groups as well. However, so we have a lot more that we would like to see there, and it would be great to have more demonstrations. So I guess what I would say is on the RNA side, it would be really important to see more demonstrations of something that we can read and get our handle on and understand. On the DNA side, since it's further along, I think we are very confident about the safety and the reproducibility of that, and that there hasn't been significant adverse events. But now expanding those and moving over the goal line is really the most important thing in the DNA space.
So, speaking of nucleic acid vaccines, there are other vaccine platforms like the viral vectors and protein and adjuvant vaccines. Can you give a little bit of pluses and minuses of your thoughts on those platforms as well?
Well, viral vector vaccines are our historic favorites. They're the kind that we made measles, mumps, rubella that most of us have taken around the planet. The newer ones are really recombinant viral vectors we're mostly hearing about. And those are really, for the most part, unlicensed technologies as well. But most of those, there have been a lot of development and there have been slow. And that is because the live vaccines have advantages in safety of these recombinant vectors over the historical vectors, and that they can't just replicate on their own for the most part, the ones most people are developing now. But their boosting and serology issues have to be really delicately worked on and tiptoed around. So they have advantages in that they can be made in large amounts, but their ability to be boosted and re-administered and things like that require a lot more work. The non-lives, we've really seen the heyday of recombinant protein, I would say, plus some of the newer adjuvants. And these are very exciting. And those tend to give antibodies and really very little or very, very poor CD8 T cells and actually weaker CD4 in most cases. And so they've been particularly advanced in certain infections where it's a single type of antibody response that's most associated with protection. However, there's a lot of safety work and all that is built around them as they're developed because of the combination of the two platforms, the adjuvant that stimulates immune response and the building of the protein and having it stay in its right shape if that's important. And so there's work in those, but those are very exciting and important approaches. And of course, it's sort of a hybrid of those that's conjugate vaccines, which is the fusing of sugar molecules to proteins, which is also very important.
So David, back to what we are talking about in this webinar, from DNA medicines, from COVID-19 to GBM, what really gets you excited about all of the potential that Inovio and the collaborators are going to demonstrate with respect to the DNA medicines in the clinical setting, both for the vaccines for COVID-19, as well as an immunotherapy for GBM?
So I can say that it's a very exciting time for the DNA field. We've spent, as you know, we've traveled this road together. It's been a very focused and accomplished, but step-by-step journey to build the platform and get it to the point where we start to see the amount of consistency we see now in the clinic, and the number of people vaccinated goes up to the thousands without significant adverse events, and the reproducible induction of antibodies and T cells in multiple trials, as well as the impacts now in cancer. The first impacts we're seeing likely mostly due to the cellular immune response that is being generated, the T cells that are CD8 T cells that are being generated, that not only are induced in the periphery, but go find the tumor, turn a cold tumor hot, so-called, when it's filled with CD8 T cells, and then can eliminate or control the tumor. I mean, these are very dramatic things that are now being reported in different papers that have been through peer review. And so, and you had very prestigious groups like David Reeder's at Harvard report on the GBM data, which is a very difficult tumor that requires generating T cells that can cross the blood-brain barrier and still have effector function, still kill. That's a very unusual thing. And so I think we're in sort of a new phase of DNA, a phase of expanding what we've already accomplished. We now see we can get responses very consistently. We kind of have established a very broad number of different diverse types of people who have received these vaccines with both disease conditions such as very serious like cancer, as well as healthy individuals, so that we now really understand a lot more about what our platform can do and how consistent it can be, and seeing responses across them. And so I think we're kind of in a new age. We're in an age where DNA can start inducing and living up to its potential, that potential we've been thinking about for a few decades now, and really cross that barrier. and provide us a really new and exciting tool for both vaccine immune responses and in the immune therapy arenas.
Yeah, absolutely, David. So lastly, what do you think is the future for DNA vaccines?
So that is one of that's a very important question. What is the future? So DNA is an enabling technology for delivery in vivo and local production of biologics that are customized by each person that receives them, and they're a chemical that we're full of, that we're used to getting exposed to, that is very natural, and really is the instructions for making something. And so some of the other exciting things besides this are, of course, the induction of biomolecules as reported with the DMAbs and the new cancer targeting self-assembling bispecific targeting reagents that the patient would make themselves, which would really open up to many more patient populations access to these type of drugs. And then self-assembling molecules that do many other things one could use as well as drug therapies themselves. So I think the vaccines and the immune therapies are an enormous thing, but they really are the scratching the surface of where we can go. And I'm going to be just so excited to see where this field goes and where we can go over the next 15 to 20 years. It should be a very, very interesting and exciting ride.
Yeah, David, I agree with you. I think we can change the face of medicine using this platform and really maximizing all of the gene products that we can deliver using this platform, from vaccines to immunotherapies to mAbs to BiTEs and bispecifics, therapeutic proteins, and I believe there's an amazing future lying ahead for this technology and this platform. So I'd like to thank you for your time and really being the true pioneer in this field, sticking with this from the beginning and really starting to see the fruits of your labor and our collective labor going forward. So thank you very much, David.
Well, thank you, Joseph. It's been an honor to be part of this group.
Great, thanks. Now it's my great pleasure to introduce you to Dr. Kate Broderick, Inovio's Senior VP of R&D and team lead for our COVID-19 DNA vaccine program. To say that Kate and her team have been working very hard is an understatement. We're all grateful to her for her leadership and dedication, as well as her expertise and meticulous approach to driving forward our INO 4800 DNA vaccine development program. Over to you, Kate.
Thank you so much, Joseph. So just starting with I think a very nice summary, and I do think that this particular slide really helps to highlight at a very tangible level some of the really key characteristics of the DNA medicine vaccine platform. In particular, I would draw your attention to the central tenet, really the foundation of the whole platform, which is the perfect marriage, I like to think, between our optimized DNA construct with our smart delivery technology. So what you're looking at here is the Selectra 3PSP device. That's our intradermal handheld device that I'll speak about a little bit as I move through my slides. But I just think that particular device really showcases Inovio's pioneering efforts in the field of DNA delivery. So the marriage of those two entities together is really what I believe is the formulation for success of the platform. And by success, obviously a key driver of that is the robust immune responses that we've been able to generate extensively in both preclinical and, of course, most importantly, clinical trials and data sets. And really, one of those key differentiators is the fact that not only are we able to reproducibly and robustly generate B cells, and by that I mean B cell responses, and by that I mean, of course, binding antibodies, but also neutralizing antibodies, but also, so importantly, those critical T cell responses, those CD8 killer T cell responses that we believe are going to be absolutely critical to the protection of some of these awful disease targets that we have assessed over the years, and of course are currently looking at with COVID-19. And of course, I'm going to come back to that a little bit as we talk through the data specifically for INO 4800. Two of the other areas you'll see on the right-hand side of the slide are kind of inherent characteristics specific to DNA themselves. Obviously, the fact that there's no anti-vector response, so that really allows us to effectively boost. Whereas some other vaccine platforms, of course, it's unfortunately a one and done due to the vector used. That's not the case for DNA. And in fact, as you'll hear with Dr. Skolnick, we can continue to boost subjects multiple times in a supportive therapy. Another area of interest, of course, is the fact that DNA itself is, of course, non-replicating and non-integrating. So there's no concerns about that from the perspective of safety or on a regulatory basis, and that's very well established and accepted by the authorities. Continuing on the right-hand side of the slide, this interesting concept that because of the nature of plasmid DNA, there's no issue with combining, or as I like to think of, cocktailing up vaccines for different targets into a single vial, thus allowing the patient to receive potentially multiple immunizations with a single treatment shot. Just as an example of that, we're working here in the R&D group together and coming up with a multi-hemorrhagic fever vaccine approach, so combining vaccines for Lassa, for Ebola, for Marburg together into a single vial, so that from the patient's perspective, they get one shot, but protection against 3 diseases. And the same, as you can imagine, can be said for mosquito-borne illnesses as well. So let's move down the circle now to the lower point, the Synchron Rapid Design. Before the last few months, I would have given you the example of our Zika vaccine development program as an idea of how rapidly our technology can be used to go from bench to bedside. And in that case, we did that in 7 months. And that was unprecedented, certainly for us, and something we were very proud of. As you can imagine, under our current circumstances, we've now really changed that whole dynamic. And instead of 7 months, we went in 83 days from bench to bedside for our COVID-19 vaccine. But I'll elaborate a little bit more on that as we move through the slides. And last, but certainly not by any means least, is a very important characteristic that I think is absolutely inherent to Inovio's DNA technology. And that is the remarkable stability profile that we have generated with our products. We specifically have come up with a formulation that allows us to completely remove the need for frozen cold chain. So I'll just repeat that again. Absolutely no need for frozen cold chain for our products. They can be stored for over 4 years at 2 to 8, so just standard refrigeration temperature. But more remarkably than that, they can be kept at room temperature for approximately a year. They can be kept at 37 for approximately 2 months. So that's really when you're thinking about deploying a vaccine, about shipping a vaccine, about storing a vaccine, those kind of characteristics are really quite remarkable. So, instead of shipping sites -80 freezers that might be required for other vaccine platforms, really just a standard fridge is all that's required for Inovio's DNA products. And then last is, of course, the rapid and scalability of the manufacturing itself. For those who aren't familiar with the way that we manufacture our DNA products. It's a fermentation process based in E. coli. For those not familiar with that, think kind of brewing beer, but instead of using yeast, we're using E. coli here. It's a very scalable process. In fact, here in San Diego, we make small batches in our benchtop fermenters. But of course, for our large-scale manufacturers, you're talking about things, fermenters much larger, approaching the size of a room. So moving on to the next slide. So looking here, so what is it inherently about Inovio's platform which makes it so well fitting for emerging infectious diseases? Well, I really believe that there are multiple areas about Inovio's technology that are just a perfect fit for responding to outbreaks like, of course, we're all experiencing right now. So I'm just going to go through each of them and maybe elaborate and just give a little bit detail on each different area. Firstly, speed. And certainly I think we're all aware of the need for speed at the moment. And when we think about traditional vaccine development timelines, gosh, potentially ranging from 3 to 20 years, that's not something that we have time for here. And that's really where DNA medicines can be very clearly differentiated. The design of the vaccine candidate itself, specifically in the case of our COVID-19 program, the whole vaccine design was completed in 3 hours. And that's really with the support of our proprietary DNA optimization algorithm that's been generated over years and years of expertise that's allowed us to upload essentially a sequence into our algorithm, and at the end of that process come out with a fully designed vaccine. Again, under the speed characteristic, the rapidity of manufacture, and I really mentioned that in the previous slide. And also, of course, the ability to harness established regulatory platforms. Okay, so that lets me move on to my second bullet point, and that is, of course, the safety profile. So we've treated over 2,000 subjects in the clinic with our DNA and our delivery technology, and over 6,000 doses of DNA totally delivered. And so far, really, we have a completely benign safety profile in the clinic. And I do think that will be a differentiating characteristic as we compare ourselves to potentially other vaccine platforms, especially in the current ongoing effort for COVID-19. Coming back to those all-important immune responses that I discussed in the opening summary slide, and just to reiterate again, one of the very powerful abilities of the DNA technology platform is its ability to produce both robust B and T cell responses. And I really think it's so vital that we have this breadth of response as we think about protection from a variety of different diseases, but specifically thinking about coronaviruses and COVID-19. Of course, we're also able to generate those all-important neutralizing antibodies too. So it's of course very important that a vaccine has immunogenicity, but truly the all-importance, of course, is that it has efficacy. So we as a team here at Inovio, we're so incredibly proud to be pioneering the path for DNA vaccines when we were the first team to show efficacy of a DNA vaccine delivered with our enhanced delivery technology to show efficacy in the clinic for our lead HPV program. Of course, that program has now proceeded into phase 3 trials, and we'll be very excited to see that data as it amasses. Of course, we've also produced and published multiple demonstrations of protection from challenge in animal models with MERS, Lassa influenza, Ebola, and Zika as examples. But the last point here is one that I would like to specifically highlight, and that's also our ability to generate immune responses in an elderly population. And we demonstrated that in an influenza trial where we specifically vaccinated people in an elderly population with, I believe, the oldest subject being 89 years old. And in that notoriously difficult to vaccinate group of people, we were able to demonstrate, of course, are those humoral responses, but also incredibly importantly, the ability to drive those T-cell responses in an elderly population. And I do think that will be a vital characteristic for our vaccines as we move forward through the clinic. And again, just to reiterate, that stability profile that we see in our DNA products is absolutely key. So as an example for COVID-19 or really any vaccine that might need to be dispersed around the globe, the ability not to have this deep frozen cold chain as part of the logistics, it will be absolutely vital. The ability for doctors' offices to store it in a standard fridge will be absolutely key to the uptake of this vaccine technology. So this beautiful timeline here really just kind of gives you a visual of where we were back in December 2019 and where we are today and where we hope to be in the near future. I'll always cast my mind back to the 31st of December when I was scrolling through my phone one morning at breakfast and came upon an article about this unknown pneumonia outbreak in China. And I thought to myself, gosh, that's interesting. I wonder what's going to come of that. And certainly I could never have predicted that we would be in the situation that we're in today. So that was really a very profound moment for me, and I think one that will stick with me for my whole career. But really, truly, it wasn't until kind of mid-January when we got access to the virus sequence itself that was really the catalyst for us being able to put the wheels of our technology into action. And as I mentioned, within 3 hours, we had a fully designed vaccine against COVID-19, which we of course now call INO 4800. From that point onwards, we went on to, of course, manufacture lots of the vaccine itself, both in a GMP format for potential human trials, but also in a research grade format to allow us to really amass a database of preclinical data to support the use of INO 4800 in the clinic. We were also incredibly honoured to receive ongoing funding support from our partner CEPI very early on to support taking our vaccine into phase 1 clinical trials. Also from, of course, the Bill and Melinda Gates Foundation, who have been very long-term partners of us, and also the US Department of Defense. So 3 great partners for us as we moved that program forward. And really that coalesced in the announcement on April 6th that we had initiated our phase 1 human clinical trial in the US of our COVID-19 vaccine, INO 4800. And remarkably, with great thanks to the volunteers and also the clinical sites that participated, we were able to fully enroll that trial in a remarkable 17 days. In mid-May, we also published our early preclinical data in the world-renowned journal Nature Communications. And as we project into the future, just a few short weeks away in June, we will be announcing our clinical trial results, and we hope to be able to very rapidly move through the processes to allow us to start our efficacy trial shortly thereafter. And of course, as you can imagine, as we push to scale up the efforts for manufacture of this vaccine, all those discussions, those extensions of partnerships and development of new partnerships are of course ongoing. So what's our internal strategy for our COVID-19 program? Well, I've kind of listed them off here, and I've tried to check off where I think we've achieved them, and you can also see ones that are still ongoing or will be positioned in the future. So firstly, we would like to achieve licensure for INO 4800 using a dual strategy of emergency use authorization and of course a traditional approval pathway too. So first check box, of course, is that we were able to move rapidly into our phase 1 study. And that is, of course, as a phase 1 always is to demonstrate safety, tolerability, and immunogenicity. And of course, we achieved that in a remarkable 83 days from bench to bedside. Prior to doing that, and in parallel to those efforts, of course, we've generated a very strong preclinical database supporting the safety, the immunogenicity, and of course the neutralization capacity of this vaccine. And we've also partnered with several labs around the world who are considered absolute experts in their area to support the generation of preclinical efficacy models. Although, of course, this is a future projection, we're aiming to be a leader to human proof of concept efficacy data. So that's getting, if the phase 1 data is supportive, which we have every confidence it will be, to move into that all-important clinical efficacy trial later in the summer. We have a strong track record of leveraging external funding to support this effort. And again, we're very grateful to CEPI, to the Bill and Melinda Gates Foundation, and to the US Department of Defense for their ongoing support to this program. We are, of course, expanding our manufacturing capabilities so that by next year, we will be delivering hundreds of millions of doses of our vaccine, which of course will be key when we think ahead to potential global vaccination campaigns. And we'll be expanding partnerships for further manufacturing scale up, but also, as we already have done, to ensure clinical trials across a multitude of demographic areas on the globe. And that's highlighted, of course, with our collaboration with Advaccine in China and IVI in Korea. So what really put us in a pole position for our work on SARS-CoV was the fact that we already, through an existing partnership with CEPI, have the lead MERS coronavirus vaccine. That vaccine is currently being tested in the clinic at phase 2, and this year we'll move into Middle East and African trial for a phase 2 trial for MERS, against the MERS vaccine disease as well. Of course, as I'm sure everyone is aware, MERS is another coronavirus related to the SARS-CoV-2 virus. So from the perspective of the design and the immunogenicity of the vaccine, I really feel strongly that put us in a very strong position where we had a foundational understanding of what a successful vaccine looked like and what successful immune responses looked like for a coronavirus vaccine. And here I'll just very quickly summarize the output of many years of work in that area. Our MERS vaccine was also based on the spike protein, so we had much confidence in that design strategy. And really we've shown that that vaccine design has a track record of success in a preclinical format. And in fact, we demonstrated 100% protection from clinical disease in a very tough primate model after 2 immunizations. But remarkably, we also demonstrated 75% protection after a single immunization. And I'd also like to iterate, and I'd love to tell the story, but I think it's out of time constraints at the moment, that we also looked at immune responses in primates, of course, mice, of course, but also in camels, which are one of the zoological sinks for this disease. So really it was that strong preclinical data set that supported the movement of this vaccine into the clinic. And of course, again, we have a track record of success there. In our phase 1 US-based trial and our phase 2 Korean-based trial, we generated 76% seroconversion after a single immunization with our MERS vaccine candidate and 80% seroconversion after 2. And those all-important T-cell responses were generated and noted at all time points. So moving on now to this next slide, and I'm the first to admit that it's rather a busy slide, but I do think that it does a very nice visual representation of really what the team at Inovio has been doing for the last few months. And I hope that it conveys to you how busy the team has been, how dedicated the team has been, and really the large levels of success that we've achieved in such a short period of time. Really, this timeline shows the efforts from the research team on the preclinical side of things. You can see all the different models that we have tested our vaccine in, and we really gives us a huge amount of confidence as we've moved into the clinic for both a safety perspective, but also an immunogenicity perspective. And you can see there, of course, we're also in the process of working towards preclinical efficacy data as well with our partners at CISRO and also our partners at Public Health England, who have also been assisting us with those live virus newt assays. As of course I've mentioned previously, all of this culminated in our ability to move into our phase 1 trial, which we initiated on the 6th of April. So what about the actual design of our INO 4800 vaccine itself? So as I mentioned previously, it really shared a lot of similarities to the design for INO 4700, which is our MERS vaccine construct, in the sense that we used the full-length spike protein. So as I mentioned, we used our gene optimization algorithm. So we received the viral sequence from the Chinese authorities. We uploaded that into the algorithm. In 3 short hours, we had a fully designed vaccine sequence. And we synthesized that into a copy of DNA, cloned that into our expression vector, and then on the right-hand side, did the necessary in vitro studies here in the laboratory to show that it was indeed producing the protein that it should. And you can see here both expression on a Western blot and also expression in vitro in cells of culture. So that box was checked. We knew it was expressing the spike protein, so immediately we moved the testing into animals. Started with small mammals, but immediately started also working on large animals, as I'll discuss in the next slide. So firstly, the first set of data here that we show is in mice. And what was quite remarkable was that after a single dose of vaccine, we very rapidly were able to detect T-cell responses. So you can see here at day 7, that with both doses of the vaccine, we were able to detect really quite robust interferon gamma ELISpot responses. And the same can be said also on the right-hand side, the humoral binding titers that you can see on the right-hand side. We move on to guinea pigs, and you may well ask, why guinea pigs? Well, it turns out that guinea pigs are actually an incredibly good, solid physiological model for human skin. And since we were positioning this vaccine to be delivered to the skin and not the muscle, as differentiates us from many of our other colleagues in the vaccine development field, we wanted, of course, to assess this vaccine in the guinea pig. And not in any way to our surprise, because we had expected this to be the case, we were able to demonstrate very robust humoral antibody titers, as well as T-cell antibody titers. But we also expanded our plethora of assays using this model and used a surrogate for neutralization, and that's really the ACE2 spike blocking that you can see on the second figure here under the guinea pig. And you can see very clearly that INO 4800 is able to block that binding. We also wanted to look at the presence of antibodies really in the organ where the disease most takes hold, and of course that's the lung. And very clearly after BAL, we were able to detect IgG biodistribution within the guinea pig lungs. And last but not least, using an in-house pseudo neutralization assay, we were able to show very clear neutralizing antibodies. Then moving on to perhaps the more clinically relevant non-human primate model, and this was in rhesus macaques. Again, we were able to replicate the data that we saw in the small animals and very clearly showed very nice cellular responses, both at a 1 and a 2 mg dose, and also very nice binding titers for both the 2 doses as well. So interestingly, certainly in the monkeys, there doesn't appear to be a huge difference in the dosing regimes. So, of course, the all-important neutralization antibodies, we were able to partner with some global laboratories who are experts in this field. For mice, we used the Chinese National Laboratory at the Peking University, and were able to detect very nice live neutralizing antibody titers. And with our partners at Public Health England in Portondown, you can see here the results of the guinea pig neutralizing titers using a live virus. And really, when you look at the levels for INO 4800, which are all over a 1 to 320 titer, because we believe that protection against the disease is coming in somewhere around the 1 to 100, 1 to 150 range. So we're way in excess of that. Of course, efficacy is the true test of a vaccine. And so, as I mentioned earlier, we are currently running several studies addressing the question of preclinical efficacy. We've partnered with CISRO in Australia to test our vaccine in a ferret model, and that data should be available in the relatively near future. And also with Public Health England at Portondown to test efficacy in the primate model as well, and that data should be available in the late June, early July timeframe. Both these models will also help us to assess the question around vaccine-enhanced disease. We do not feel that there is any likelihood that our platform will be impacted by that, on the basis that we didn't see that for our MERS data. But I think it's an important safety box to check, and we'll be able to do that with these challenge studies. So what about the progress in the clinic? So we very rapidly moved from preclinical testing straight into phase 1 testing, and we did this in partnership with Dr. Pablo Tebas at the University of Pennsylvania, and also the AMR site in Kansas City, both of whom we're extremely grateful to for their support and their determination through this rapidly evolving process. We started a small phase 1 study, 40 healthy volunteers, to really gain a preliminary assessment, of course, of safety, tolerability, and immunogenicity. The sites were extremely motivated, as were the volunteers themselves, and again, just so grateful for their time and their effort in being involved in this study. And really that, again, to highlight that unprecedented speed that we went 83 days from plasma design to testing, to treating our first subject in the clinic, and full completion of enrollment within 17 short days. So really very, very exciting time. And we hope, of course, to be announcing the data, at least the interim early read data from this trial, in the June timeframe. So really just a final slide to really give a huge shout out to the team at Inovio here. I can't convey my honor to work with these people every day, to convey to you, the listeners, the determination of these people who have truly worked night and day to get us where we are today. And it's an honor, I think, for the whole team at Inovio to be able to be working towards a solution for this terrible outbreak that we're all experiencing at the moment. And of course, it would be only correct to thank again our fantastic partners and supporters who have been really with us this whole journey over these few short months, but incredibly busy months. And again, I would like to verbally thank CEPI, the Bill and Melinda Gates Foundation, for their financial support, the Department of Defense for their financial support, for DITRA for their financial support, and also our partners, our collaborative partners at IBI, Advaccine, at CISRO, Public Health England, the Chinese National Laboratory, the Wistar Institute, and the University of Penn, all who have made this process possible. So I thank you so much for your time and hope that this has given you some insight into our activities over these last months. And also I hope that it gives you some hope towards the potential possibility of a DNA-based vaccine against COVID-19 that is both safe and effective in the clinic. And that just leaves me now to introduce a conversation that I had recently with Professor Stanley Plotkin to talk about the COVID-19 outbreak. It's an absolute pleasure to be here today and to be able to introduce Professor Stanley Plotkin, who shouldn't really need introduction to anyone because he's so very clearly a luminary in the field of vaccine development. So, Professor Plotkin, it's such a pleasure to have you here with us today.
Thank you.
So as we touch on vaccines, and as of course you are literally the world expert on it, I'd have to ask you, Professor Plotkin, what characteristics are we going to need to see in a successful vaccine for COVID-19?
Well, I think the most important characteristic of a vaccine against SARS-2 will be to protect the respiratory tract. Or put it another way, to prevent the virus from spreading from the upper respiratory tract to other parts of the body. Now, it may be that a vaccine, successful vaccine, will not prevent infection because we know from other vaccines that frequently the case is that the effect on mucosal replication is not terrific. Now, with live attenuated vaccines, we often do control mucosal replication, but with non-living vaccines, it's often the case that mucosal replication can occur, but systemic invasion does not. So what we have with this coronavirus is a virus that is able to infect the upper respiratory tract, and which, because the receptors of the virus exist in the lower respiratory tract as well as the upper respiratory tract, it can spread downwards. And what blocks it, or what blocks other agents as well in the lower respiratory tract, is the presence of antibody. And so that is the first goal, should be the first goal of a successful SARS-2 virus, to produce antibodies that can bathe the lower respiratory tract. Whether it prevents upper respiratory infection remains to be seen. One, of course, would like that to be the case, but I don't think we can be sure that that will be the case, even with a vaccine that protects the respiratory tract. Now, the other aspect of this coronavirus, which is unfortunate, is that it produces immune responses that can be exaggerated. So the so-called cytokine storm, and in particular, the cytokine IL-6, and that cytokine storm, even when the virus replication has begun to disappear, can kill the patient. Now, we don't yet really understand the phenomenon. We don't understand how this virus does that. But I suspect that cellular immune responses will be important in preventing that. Now, this has to be cellular responses that are just right, in a sense, that both CD4 and CD8 responses that can control the infection and prevent this late phenomenon of exaggerated immune responses and production of cytokines. But that is a phenomenon which I'm not sure anyone anticipated, and we're just beginning to learn how to deal with. But for example, with antibodies, monoclonal antibodies against IL-6. But my point here is that we have two separate phenomena that we want to control: the virus replication and also the host response, the exaggerated host response. Now, just one last point is, at least to me, I don't yet understand why the exaggerated response is occurring largely in the elderly. In a way, that seems counterintuitive, since the elderly, the immune system is not as good as it is in the young. Yet, this exaggerated response is occurring in them. And I think we need to learn a lot more about the physiology of that response and what it is about the elderly that permits that response to occur.
So, Professor Plotkin, you may be aware that we at Inovio published our first manuscript containing data of our own SARS-CoV vaccine. This is called INO 4800 in Nature Communications. I don't know if you've had a chance to look at that publication yet.
I've seen the early data with the Inovio vaccine. They're very promising. And of course, what we need now is to show that indeed the immune responses are protective. Clearly, we want a vaccine to induce antibodies against the SARS-2 virus. But there are other responses also which may be critical to control. And therefore, we have to analyze deeply the immune responses that are produced by different vaccines, because they almost certainly are different. The contrast, I guess, could be between the DNA vaccine and the inactivated virus vaccine that is being produced. I would be very surprised if the responses were identical. I feel pretty certain that they're not. And what we need to know is what are the important responses, physiological responses. Anyway, my point here is that not only the height of immune response is important, but the breadth of immune responses. And immune responses are multiple. They're not only what we show in a neutralization test by incubating a virus with serum.
Yeah, and certainly something from our perspective, Professor Plotkin, that we were so proud of and were able to publish in that Nature Communications manuscript was our ability to generate robust antibody responses, including neutralizing antibodies, but also those T-cell profiles too. And I think that tends to be kind of a key characteristic of DNA vaccines. Certainly one question that I'm asked frequently, and I can understand why, is that kind of compare and contrast DNA vaccines to RNA vaccines. So I would really love to hear your opinion on that.
Well, so my simple response, or simplistic response to that question, is that there's no doubt that the DNA vaccines induce strong cellular responses, and they may well be critical depending on the agent that you're talking about. We don't have head-to-head comparisons, We, as you know, we have heard, we don't have a lot of data, but we have heard that the first mRNA vaccine produces an antibody response, a neutralizing antibody response. The trouble, of course, is that we can't really compare until serum specimens are available from both types and can be run in the same laboratory. But I guess my question about the mRNA at this point would be not only the height of the antibody response, but also what kind of cellular responses are produced by mRNA vaccines. And I think we will have this information in the next couple of months, I would expect.
Yes, indeed. It's an unusual situation that we find ourselves in today. I don't know, certainly not in my career, and I don't know about yours, sir, but you know, the opportunity to really have head-to-head comparisons of vaccines in kind of real time. I don't know that we've ever had that opportunity before. So it's going to be an interesting few months to be able to analyze all that data together. Could you talk about specific characteristics that you think might be advantageous to our Inovio INO 4800 vaccine and how it might be particularly appropriate for the COVID-19 outbreak?
Well, so I think I would go back to what I was alluding to before. The positive thing that I see is that DNA vaccines can produce a broad range of immune responses. And we don't know for sure what the immune responses to SARS-2, which immune responses are critical. But I think we can infer that certainly antibody is going to be critical. And as I said before, I think that cellular responses will also be important in view of the pathology that we're seeing with the disease. And there, of course, I would mention the Th1, Th2 dichotomy that for most vaccines, one really prefers the Th1 response. And I think that's definitely the case here for SARS-2. So from my point of view, the more approaches available, the better, because this is the first time, I think it's really the first time in history that we will be, in principle, trying to immunize 7 billion people as soon as possible. And the only way that that could be possible is if we have multiple different vaccine producers producing at high quantity levels. So the world needs a plan based on what we hope is multiple successful vaccines, a plan to produce them and to distribute them. And that's not going to be easy.
You ended that very important answer talking about the need for governments to form a consensus, really, in regards to the global access of this vaccine and its distribution. You and everybody listening to this discussion will have heard the timeline of having a vaccine ready for fairly widespread distribution in the 12 to 18 month timeline. Do you, sir, as an expert in the area, think that is achievable?
Well, long life has taught me never to make predictions. But all that one can say is if everything goes well, Yes, but that is a big assumption that everything goes well. Um, I think it's feasible to produce a certain amount of vaccine. But again, if we're talking about 7 billion or potentially 14 billion doses, I cannot imagine that they would be available in 12 to 18 months, unless there is a plan made now how to do that. Who's going to do it? How is it going to be done? Where is it going to be done? So will there be a successful vaccine in 12 to 18 months? I think so. I think it's likely. Will there be enough vaccine to immunize everyone? Big question. I remain dubious about that.
So my final question for you, Professor Plotkin, and this might require a fairly lengthy answer, but so once we get through this outbreak, and I personally believe that we will, it's just a matter of time, and obviously the development of a successful vaccine will be critical to that. But when we do get through this, how do you think the experience of the COVID-19 outbreak is going to shape vaccine development in the future?
Well, that's of course a very interesting question. So perhaps a few obvious answers. One is that we will have, fortunately, more strategies, successful strategies to develop vaccines. That is the most positive result of this epidemic. We'll have more tools to make vaccines. Another result, I hope, that the realization that there are numerous viruses out there replicating in animals that could transmit to humans, that could adapt to humans. And I'm not the only one saying this. This has been said by other people before, and one can identify many likely suspects and study them so that you are prepared. It would have, I guess the most obvious thing to say is that had we gone on to produce a vaccine against SARS-1, we would be in a better position to know what vaccines against SARS-2 will do. Unfortunately, we didn't do that. But I think the lesson is to be ready for adaptation to humans of viruses in the environment. And, it's not just SARS. Zika is another example. Zika was isolated first in Africa, not in humans, by the way. It was in primates, and then began to adapt to humans and began to spread. And we didn't do anything about it until it spread to Latin America, and the effect on the fetus in utero was demonstrated. Now, we should have actually, if that had really been studied, it happened in French Polynesia first. So we should have been ready for that, but we weren't. And so I think those are the things we really need to do to appreciate that nature is dangerous and that we have to, even with our civilization, we have to be ready for natural disasters.
thank you so much for that fascinating reflection. It was absolutely stunning to listen to. And I just would like to thank you so much, Professor Plotkin, for your time today, your insights, sharing your great extensive expertise in this area. It was absolutely fascinating, and thank you so much for taking time to talk to me today.
You're quite welcome. Bye-bye.
Well, I'm so grateful again to Professor Stanley Plotkin, who was able to join us and share his fascinating insights on the current COVID-19 outbreak and talk so eloquently and so fascinatingly about our DNA platform technology. So it's now my absolute pleasure to pass the baton over to my friend and colleague, Dr. Jeffrey Skolnick, who leads our clinical oncology programs, who's now going to talk to us about our DNA-based immunotherapy programs here at Inovio.
Thanks very much, Kate. Today we're going to talk about glioblastoma. Glioblastoma, a brain tumor, is an aggressive, fast-growing tumor of the supportive cells of the brain called glial cells. Glioblastoma is also called grade 4 astrocytoma, a high-grade brain tumor. Patients with glioblastoma, or GBM, can present with headaches, nausea and vomiting, seizures, memory loss, weakness, or other neurological symptoms that are specifically related to the location of the tumor in the brain. And symptoms appear very quickly because GBM is so very fast-growing and so very aggressive. Glioblastoma is almost always diagnosed at resection during surgery, and that's the diagnostic procedure of choice. Standard therapy for patients with GBM include primarily surgery, as well as radiation and often chemotherapy with a medication called temozolomide. Prognosis for patients with GBM remains very poor, and GBM is almost always fatal. And unfortunately, there have been few, if any, changes in the treatment of GBM for over 20 years. Survival after diagnosis for most patients is just over a year and is rarely more than 3 years. And so it's clear that the unmet medical need in treating patients with GBM is there. As you can see from the graph on the left, despite data that are now over 10 years old, the prognosis for GBM, as we've said, is very poor. And even with what at the time was considered state-of-the-art, the introduction of chemotherapy to radiation and surgery, we have not seen a significant improvement in overall survival for patients with this terrible disease. In fact, the addition of what was considered practice-changing, temozolomide chemotherapy, was only an addition of approximately 2 months of overall survival. Inovio's study of INO-5401, encoding for 3 novel DNA medicines, tumor-associated antigen-encoded plasmids for hTERT, or human telomerase, WT1, Wilms tumor 1, and PSMA, or prostate-specific membrane antigen, are being given with Inovio's novel IL-12 plasmid, INO-9012, in combination with Regeneron's PD-1 checkpoint inhibitor cemiplimab, or Libtayo, in patients with newly diagnosed glioblastoma. Following surgical resection, but within 42 days of starting radiation, patients receive the novel DNA medicines INO-5401 and INO-9012 in combination with cemiplimab, and continue to receive those therapies approximately every 3 weeks. Radiation and temozolomide is given for 3 weeks, and temozolomide is continued in a subset of patients. Patients continue this novel trial therapy until progression, receiving cemiplimab every 3 weeks, and eventually spacing out their Inovio 5401 and Inovio 9012 to every 9 weeks. The study is enrolling 2 different types of patients. Cohort A, which has enrolled 32 patients, is enrolling MGMT promoter unmethylated patients who tend to have a poorer prognosis than patients in Cohort B, those with MGMT promoter methylated tumors, of which this study recruited 20 patients. Patients are followed for disease progression as well as for overall survival on this study. And the study, which is a phase 1b/2, is also assessing the safety and tolerability of this novel combination together. Very importantly, the study is assessing the novel medicines INO-5401 and INO-9012 with cemiplimab with radiation and temozolomide chemotherapy. Inovio has previously shared our 6-month progression-free survival data at the SITC SITC 2019 meeting last year. During that meeting, we shared that our PFS6 rate in MGMT promoter unmethylated patients, Cohort A, was 75%. And for Cohort B, MGMT promoter methylated patients, our PFS6 rate was 80%. And these compare very favorably with historical values of approximately 40 to 60%. Very importantly, we demonstrated immunogenicity and obvious evidence in patients tested of T cells that were antigen-specific to 1, 2, or all 3 of the tumor-associated antigens encoded for in the plasmids in 5401. We were also able to demonstrate the phenomenon known as pseudoprogression, in which patients appear to have progression of their tumor, but in reality have an immune response appropriate to the novel therapy that they are receiving that over time improves, suggesting that our medicines may be acting at the site they need to and doing exactly what they should be doing, that is, using the immune system to fight this terrible tumor. More recently, we have released our promising 12-month overall survival data. These have been shared at the ASCO 2020 meeting just recently, and very exciting data where we were able to demonstrate at 12 months an overall survival rate of 84.4% in promoter unmethylated patients and of 85% in promoter methylated patients, cohorts A and B respectively. And again, this compares favorably with historical values of approximately 65%. Once again, we demonstrated an immune response in patients assessed to date. All 3 antigen encoded for in INO-5401. Importantly, we were also able to show that the combination of INO-5401 plus INO-9012 with the checkpoint inhibitor cemiplimab was well tolerated when combined with radiation and temozolomide chemotherapy. And altogether, we are extremely excited about these data demonstrating an overall survival rate at 12 months of approximately 85% in all patients on this study. It is my extreme pleasure to welcome Dr. David Reardon, the Clinical Director for the Center of Neuro-Oncology, Professor of Medicine at the Dana-Farber Cancer Institute, and Professor at Harbor Medical School, Boston, Massachusetts, in a conversation in which we'll talk about DNA immunotherapy and glioblastoma. Welcome, David.
Thank you very much, Jeff.
Dr. Reardon, we've just learned a bit about glioblastoma as a disease. Can you share with us a bit about the history of the treatment of GBM and why it's such a difficult disease to treat?
Sure. So glioblastoma, the number 1 or most frequent malignant cancer arising in the brain in adult patients, has historically always been one of the most difficult of cancers to treat. Historically, we have relied on surgery, which, as you can imagine, is challenging and difficult in the brain for tumors that are intrinsic arising in the brain. But nonetheless, significant technological advances have occurred over the last decades, and in particular in the last few years, to allow our neurosurgical colleagues to effectively debulk the main mass, macroscopic mass of the tumor in a significant percentage of patients. Glioblastoma, however, is a disease that is remarkably infiltrative and invasive, although it does not metastasize, and that's a mystery why this tumor rarely metastasizes. But it makes up for that capability by being incredibly invasive and infiltrative into the adjacent brain and cerebral cortex. So surgery is very helpful at decompressing the macroscopic mass, which can often improve symptoms for patients. But unfortunately, it's not curative. The tumor will come back, and oftentimes come back in a fairly short order, even with an aggressive resection. So we have traditionally relied on additional cytotoxic therapy for patients after surgery, maximal safe surgical resection is performed. And that, for many years, was radiation therapy alone. Back in 2005, after many attempts to demonstrate that chemotherapy could have an impact on the outcome of this disease, Roger Stupp and colleagues from the EORTC and the NCIC north of the border in Canada demonstrated that a chemotherapy drug, temozolomide, when added to radiation therapy, could improve survival for patients. And at that time, that became our standard of care for newly diagnosed glioblastoma patients. Maximum safe resection, radiation therapy, which is typically given Monday through Friday over 6 weeks, that is the historical dogma, along with the chemotherapy drug temozolomide. And temozolomide is given during radiation therapy and then for monthly cycles for approximately 6 months after radiation therapy is completed. That has been our historical standard of care. There have been a number of clinical trials, including randomized phase 3 studies, trying to improve on that standard of care, and so far those efforts have not been successful. So today in my clinic, 14 to 15 years after that standard of care was established, we are still offering that to our patients as their best established treatment intervention. The reasons we haven't been able to improve outcome for patients with this challenging tumor, there are several. We have learned tremendously about the biology of glioblastoma over the last decade and few years in particular, but it's been very challenging to translate those advances from the laboratory and from the basic science research done on these tumors into effective and improved treatments for patients. First of all, we're dealing with a tumor that's arising in the brain, and by definition, we have to overcome the blood-brain barrier that Mother Nature designed our central nervous system with to protect it from any potential toxic or noxious exposures. Unfortunately, that level of protection also excludes most of the chemotherapies and many of the biologically based therapies for cancer. Fortunately, our immune system very readily passes through the blood-brain barrier and goes back and forth between the systemic and central nervous system compartments quite readily. So immunotherapy, unlike cytotoxic therapies and many of the biologic targeted therapies, we do have an advantage where mobilized immune effector cells can move into the tumor in the brain very readily. Another significant challenge with glioblastoma, which is not unique to glioblastoma, but I think probably optimized to a degree more so than in most challenging cancers, is the ability of this tumor to adapt and become resistant. What I tell my patients is that we have treatments that can help the majority of patients. The problem is the durability of those treatments, how long they can last, and ultimately the tumor's ability to adapt and become resistant. The other factor I think that contributes to a significant challenge in developing therapies for these tumors is that we've learned they are remarkably heterogeneous, not only from patient to patient, but even within the same patient. areas and regions of the tumor may be markedly different in terms of the dysregulated cell signaling pathways that are giving the tumor cells a growth advantage, the blood flow patterns within the tumor, hypoxia, other physical features within the tumor. All of those things can vary markedly within the tumor, within an individual given patient's tumor. I think underscoring the fact that this is not likely to be a tumor where a one-size-fits-all approach can be applied, that we're going to have to better understand what's unique and different ultimately about each patient's tumor, and then cultivate complementary combinational therapies that are best suited for that individual patient.
As you noted, the human immune system may be somewhat privileged in that it doesn't necessarily have the same challenges overcoming the blood-brain barrier as, for example, a drug or therapeutic might have that was either small molecule or something similar. Can you speak more about that and what we're learning about the opportunity for the immune system to approach and then overcome any challenges with the blood-brain barrier?
Sure. As I mentioned, glioblastoma is a remarkably infiltrative tumor in the brain. What we can see on the MRI scan is typically a mass that highlights with contrast uptake. And that's what I refer to as the macroscopic portion of the tumor. But emanating outward from that microscopically, typically for several centimeters, even crossing over into the contralateral hemisphere, are microscopic cells, microscopic tumor cells that are moving outward. And in that part of the tumor in particular, where we do not see contrast uptake, the blood-brain barrier is completely intact, and molecules based on their size, their chemical structure, and electrical charge will be excluded from penetrating through the blood-brain barrier. The blood-brain barrier also includes a number of efflux proteins that are designed to, if a molecule can pass through based on its physical properties, these efflux proteins are designed to bind to some of those molecules and exclude them, or pump them right back out again. And unfortunately, based on those mechanisms, most of the cancer therapies that we're currently using for other systemic cancers just completely don't get through where the blood-brain barrier in particular is intact. Our immune system, including the effector arm with T cells and B cells, can readily penetrate through and move into the central nervous system. We know when our patients have inflammatory conditions or infections, the immune system readily mobilizes into the brain and is quite active in those processes. So our goal with immunotherapy for brain cancer is to tap into that capability and prime or optimize the response of the immune system against the targets within the tumor, and begin to break down some of the evasive protective mechanisms tumors like glioblastoma have put in place to seal themselves off and prevent the immune system from successfully attacking.
And are you beginning to see in the clinic, even in clinical trials, evidence that therapies that can and do stimulate T cells showing promise in patients with GBM?
Yes, but it's still very early. The signals so far are modest at best, but we know, for example, that glioblastoma is a prototypic immunologically cold tumor with a very low density of immune effector cells in the microenvironment of the tumor. Those effector cells, CD8 and CD4 cells that can penetrate into the tumor, typically are exhibiting either an exhausted or a dysfunctional phenotype. So even if they can get in, they're not able to function very well. So therapies that can enhance activation of these effector cells and help facilitate their movement into the tumor is a critical first step. And some of the robust vaccine treatments that have been evaluated have indeed been able to show, when looking at tumor samples obtained prior to vaccination and then after vaccination, that there can be a significant influx of these effector cells after a proper or robust priming of the immune system against tumor targets. So I think that's certainly a critical step. We've got to get the cells into the microenvironment in the first place if the immune system is going to have a chance.
We're certainly excited by the data that we have currently, the 12-month overall survival, and we're absolutely looking forward to the 18-month overall survival later this year. We started by talking about, and you mentioned 3 challenges treating GBM. I'm wondering, as we conclude, is there one thing that you are most excited about right now in treatment of GBM?
Well, I think we are still in very early stages of understanding the mechanisms of how glioblastoma protects itself and suppresses anti-tumor immune responses. And I think there's great effort that's being focused on this, advancing this knowledge and this understanding. I think we are making progress. I think we're overcoming some of the challenges, or coming up with strategies that have the potential to overcome some of those strategies, some of those challenges. But I think we still are in very early days and need to learn a lot more about understanding the complexity of this tumor. Glioblastoma, I think, is has been one of the most, if not the most difficult cancer to treat, for good reason, because it is very complex, and we know from a variety of different angles, whether it be DNA repair, whether it be dysregulated cell signaling, whether it be angiogenesis, and now we're learning about cancer immunology, that it has multiple levels of protection, multiple redundancies built in to give those tumor cells a tremendous growth advantage. And we're going to have to learn more about those factors that glioblastoma tumors have put in place, and then design appropriate therapies to overcome those challenges. I think we have great excitement in the field of cancer immunology and immuno-oncology based on precedent and validation of immunotherapy approaches now across the spectrum of cancers, including melanoma, that in its day, before immunotherapy came along, was as equally refractory to treatment as glioblastoma in terms of lack of response to chemo and radiation and targeted therapies, other things. That immunotherapy has made a difference in other cancers, and we just have to figure out more about how we can utilize the power of the immune system and overcome some of the protective mechanisms glioblastoma tumors have put in place. And I have no doubt that we will get to a point where immunotherapy becomes a cornerstone of glioblastoma therapy as well. And I hope our combination approaches, our innovative combination approach with the multi-antigen targeting vaccine and upregulation of IL-12 that the Inovio plasmid platform provides for us, coupled with PD-1 blockade, could be an important step forward as we move along in this overall strategy and approach.
Dr. Rudin, I wanted to sincerely thank you for taking the time to speak with us today. It is, as always, a pleasure to learn from you and to speak with you. And thank you for sharing your expertise with us.
It's my pleasure, and I'd like to thank everybody at Inovio for all of your hard work and all of your commitment to improving outcome for our patients, not just glioblastoma patients, but all of the cancer oncology patients that you all are working for across your portfolio. And on behalf of our patients and families, thank you so much.
Thank you. Please be safe.
You too, Jeff. Thank you.
Thank you to all the panelists for your participation and insight. At this time, we will be transitioning to the questions and answers segment of the webinar. Joseph, the general question from investors is, what is the timeline for bringing INO 4800 to market? Can you speak to the timing of clinical readouts and manufacturing scale-up? And also, will Inovio submit for emergency use for INO 4800?
Yeah, thanks a lot, Ben. So as Kate Broderick mentioned, we're taking a dual approval approach for INO 4800. We feel that late this fall, early winter, we will have enough data to apply for emergency use authorization for INO 4800 if that path is a viable path as determined by the FDA and the HHS. At the same time, we expect to have our phase 1 data from our first 40 subjects in late June, hopefully positive, and allowing for us to move to our large randomized double-blinded phase 2/3 efficacy trials, which we expect to start sometime in July/August. That would allow for us to have the efficacy data early next year, if not earlier, because this would likely be a case-driven study. So we're very excited to approach this dual path through EUA and the traditional approval pathway.
Great. And just a quick follow-on, Joseph. What amounts of funding does Inovio need, and when would we expect it, and from whom?
Yeah, as we already mentioned, we have received supportive funding for INO 4800 from CEPI, Bill and Melinda Gates Foundation, and the U.S. Department of Defense. We expect these type of funding to continue as we progress, both from our preclinical studies that's ongoing in parallel, as well as positive phase 1 data that we expect to have before the end of June. As we move forward with the large efficacy trials, and as we scale up our manufacturing processes to be able to provide hundreds of millions of doses in the coming year, we do expect to receive external funding that's appropriate in proper preparation for these two activities. So we look forward to providing those information when they become available.
Thanks. Switching gears real quick, a question from Charles Duncan with Cantor is, in the recent ASCO presentation on GBM, can you provide a general sense of how does the 12-month results read through to expectations for OS 18 later this year? We understand that this is a small sample size, but what is your perspective on these results, and how do they compare to historical 12-month overall survival data for these populations?
Yeah, I'll turn over to Jeffrey to provide his thoughts. As we had heard from Dr. Reardon and Jeffrey Skolnick earlier. But I'm very excited. I think OS 12, while it's still early, it's later than PFS 6. So we can continually show a consistent efficacy advantage of our treated patients over the standard of care. But I want to turn over now to Jeffrey Skolnick, who can provide additional insight on our GBM program and potential OS 18 later this year.
Thank you very much, Joseph, and thank you for the question. So I share Joseph's excitement around OS 12 on our GBM study. You know, as we've literally just shared at ASCO this past weekend, we're looking at approximately 85%. So in the unmethylated patients, again, 84.4% OS 12. The methylated patients, 85% are alive at 12 months for OS 12. And as you heard Dr. Reardon say, and as we've shared just a few moments ago, this is an extremely hard disease to treat, in which, in general, the median overall survival is about a year or more, specifically in those unmethylated patients. So the fact that at 12 months we are at 85% is extremely encouraging. It's promising, it's early, but I sincerely hope that that trend will continue into the OS 18 time point, which we'll share later this year. Again, I think we are very encouraged by what we're seeing at 12 months. 18 months, hopefully, will continue that trend.
Great. Thank you, Jeffrey.
Great. Thanks. A question from investors is, biologically, what is going on that drives the neutralizing antibody generation to decrease so significantly from mice to non-human primates to humans?
Well, as Kate presented, and I'm going to turn to Kate for additional insights. We've demonstrated very strong neutralizing antibodies in mice and guinea pigs. We are currently undertaking those assays in non-human primates. So I think that question isn't exactly accurate because we don't have that data yet. But I'm going to turn to Kate and how these animal models are pertinent and how they may be predictive to what we may see in clinical studies in human beings. Kate?
Thanks, Joseph. Yeah, I'm not sure that I understand the question, so let me maybe offer my opinion just on this broad general area. So certainly, mice is a very standard model for testing vaccines in. There's a lot of reagents available, etc., etc. But really, of course, as I think we're all aware, the most clinically relevant model, of course, is the primate model. Second only, of course, to the human being themselves. So, we've generated very robust neutralizing antibodies in mice and in guinea pigs. We're working on the primate samples at the moment. It's just a little bit more complicated in shipping primate samples around the world than it is for other species of animals. I have every hope that they'll look robust too, and I say that on the basis of the neutralizing antibodies that we saw for MERS in the primates. And of course, we're very excited in the June timeframe. Gosh, it's already the 1st of June today, but in the June timeframe to be able to also be showing the neutralizing antibody data from the humans. And I'll pass it back over to Ben.
Thanks, Kate. Just a quick follow-up too. Why do you think it is that roughly 50% of patients in your MERS and Zika studies generated neutralizing antibodies while the rest did not? Is there something biologically driving this difference in responses?
Well, look, I can take that on. The MERS, every virus is different. And I would say our published MERS neutralization data in Lancet Infectious Diseases is as good or better than anyone else who has published from a MERS vaccine clinical studies. In fact, what was just presented in May at ASGCT, we were able to demonstrate very strong neutralizing antibody up to 92% of the vaccinated healthy volunteers with our intradermal delivery of INO 4700. So I think the question is a little bit off, but what we aim to show is what our vaccine can demonstrate, targeting a specific antigen. In a COVID-19's case, it's the spike protein of SARS-CoV-2 virus, where we hope to show in our clinical trials is strong binding and neutralizing antibody titers, as well as very potent and robust T cell immune responses, both CD4 T cells and CD8 T cells. I know Professor Dave Weiner and Professor Plotkin both expounded on the importance of T cells in controlling infection and providing protection. So what we hope to show in our clinical trials, along with our supportive animal data, is that we can robustly produce both vaccine-generated antibody and T cell responses, and that's what we hope to show later in June.
Great, thanks. Question from Greg Renza with RBC regarding GBM. He wants to know, how will you tease out the efficacy resulted from the immune responses from INO 5401 with cemiplimab and the GTR? He noted another ASCO presentation from Genentech looking at atezo in combination with temozolomide and radiation in patients with newly diagnosed GBM also showed over 80% OS12 in the population after GTR. How do you think our data compares with this?
Well, I'll turn it over to Jeffrey to address the GBM question.
Thanks very much, Joseph. Greg, thanks for the question. So, to your point, We do know that single agent checkpoint in glioblastoma has not demonstrated the efficacy that we've wanted to see. That's specifically been in large phase 3 studies. And this past weekend again at ASCO, we did see new evidence to suggest that there may be, again, some hope, as you have highlighted, in specific combinations with checkpoint. But I think that's exactly the point, that it's the combinations specifically with 5401 that we think makes the difference in our study, and that we can use to some extent the single agent checkpoint data previously to say that you need something else, not only to unleash the immune system, but really to bring those T cells, for example, those that are antigen specific that are being created by 5401 plus 9012, to make an efficacy difference. I wouldn't compare across studies. Again, we know that these are still early days in small numbers, but I do think that the data are there to suggest that it's that combination with 5401 specifically and not checkpoint alone that's going to make the clinical difference. Thank you.
Great. Thanks, Jeff. As we've hit that time, thank you everyone for your questions. This concludes the Q&A portion. I will now turn the presentation over to Dr. Joseph Kim for closing remarks.
Thank you, Ben. What I really want to stress right now is what we have demonstrated from our DNA medicines platform, where whether we're targeting COVID-19 spike antigens or GBM antigens, they're prevalent in multiple types of tumors, including GBM. Inovio's DNA medicine that's targeting those antigens can generate very strong immune responses, in particular antibody-based responses and T-cell-based responses. And consistently, we're showing potentially these immune responses in human beings can drive clinical benefits. And we are hopeful that we can continue to show this in our COVID-19 vaccine program going forward, from phase 1 studies, phase 2/phase 3 studies, and so on, to a licensure of the vaccine. And then in GBM, we will continue to track our current phase 1/2 patients to OS 18. And we're hopeful that our clinical benefits that we're seeing in these early times can be translated into later times, and we would have a path forward quickly to a potential licensure going forward against this cancer that is highly devastating. As we promised, we would end at noon today, so that as we conclude, if we didn't get to all of your questions today, please contact our IR team. Thank you again for joining us, and we hope we provide you with an understanding of the breadth and depth of our DNA medicines platform. Revolutionary power of our technology is superseded only by the dedication, passion, and expertise of the team we have brought together to bring our technology to life for patients in need and for humanity. I want to thank especially to our Inovio team, their families, our fantastic global partners, and our shareholders for their commitment and support of our mission. Thank you again, and be safe.